I am Josep Rodés-Cabau, interventional cardiologist at the Quebec Heart and Lung Institute, and I'm also affiliated with the Clinic Barcelona Hospital in Barcelona. After the intervention, which is a left atrial appendage occlusion, you need some antithrombotic therapy to prevent device thrombosis following the procedure, which in fact remains one of the most frequent complications of the procedure, which is nowadays a very safe procedure. And this antithrombotic treatment strategy has evolved empirically. There have been multiple regimes, and the most common one in this population was dual antiplatelet therapy for several weeks after the intervention. More recently, there were data suggesting that direct oral anticoagulants seem to be superior to dual antiplatelet therapy. Some observational studies, one small randomized trial, are showing this, meaning that the idea of Andes was really to demonstrate the potential superiority of DOAC versus DAPT for these patients. This was a prospective randomized controlled trial, investigator-initiated, and that randomized patients with non-valvular atrial fibrillation undergoing LAA occlusion. Patients were randomized to DOAC or DAPT 1:1, and the primary outcomes of the study was device-related thrombosis, as evaluated in an echocar lab, in patients taking the allocated treatment at 60 days. The treatment was, I forgot to say, treatment was of 60 days. And then we had a safety outcome, an intention to treat analysis safety outcome, including a combined endpoint of death, bleeding, stroke, and device thrombosis, the site reported, not echocar lab. The patient population of the study was a population consisted of 510 patients, half of them randomized to DOAC, half of them randomized to DAPT. And the mean age of the population was 77 years, high thrombotic risk, CHA2DS2-VASc score above 4, high bleeding risk, HAS-BLED score above 3, and the majority of patients had a prior bleeding event before the intervention, which is quite representative of a real-world practice in most of the centers doing these interventions nowadays. The primary efficacy endpoint, that was device-related thrombosis, occurred in 1.5% of the patients in the DOAC group versus 4.1% in the DAPT group. Despite of this numerically lower rate in the DOAC group, these differences didn't reach a statistical significance. For the safety outcomes, we had a significant reduction of adverse events in the DOAC group compared to the DAPT group. It was about 23% of events in the DOAC group versus about 35% in the DAPT group, and these differences were highly significant. And these differences were mainly related to a decrease in bleeding events in the DOAC group compared to the DAPT group. I think that despite that we missed the primary endpoint, we showed the improved safety profile of DOAC, and we showed also a clear tendency towards a reduction of device thrombosis events in the DOAC group, meaning that I think that while waiting for further data, DOAC seemed to be a reasonable and likely safer antithrombotic strategy in LAA occlusion recipients. I would say that the message could be also that probably DAPT, dual antiplatelet therapy, is probably not a very good therapy for this intervention. And then we can discuss about if we can move towards half dose of DOACs or to single antiplatelet therapy in order to reduce the bleeding risk. But I mean, my opinion, this study points out the fact that that had really no benefit. You had a numerically higher rate of device thrombosis, even if it was not significant, was a clear tendency, and you had much higher rate of adverse events, particularly bleeding. I think that despite of this therapy has been recommended in guidelines, in consensus papers, etc. I think that in the future is not going to be used much in this population. I think that DOACs seem to be a good strategy in these patients. The next question will be which dose. In Andes, we use the usual dose of DOAC for these patients, but there are studies suggesting that half of those would be enough to prevent device thrombosis while reducing the number of bleeding events. This is an important question. And then in patients with a very high risk bleeding score, maybe with the newer generation devices, we can explore the possibility of single antiplatelet therapy to see if the device thrombosis rates are reasonable while reducing again the rate of bleeding events. However, with the results of Andes, we anticipate that if we go to single antiplatelet therapy, the numbers probably in terms of device thrombosis will be similar, if not higher than those observed in Andes, meaning that I think that in the future, for sure, we will have to go more with the less intensive therapies, probably for a group of patients, in patients that can take anticoagulation, and LA occlusion is a real alternative to that. These patients can take a DOAC with no problem for a few weeks. But for those with high bleeding risks, probably we will have to think about less intensive strategies.